Hi everyone, this is Dr. Bisal Gewali from Queen's University, Kingston, Canada. Today I wanted to share some of my thoughts about the final overall survival results from the PALOMA-2 trial. As you know, PALOMA-2 trial is the trial testing the addition of palbociclib to letrozole in the first-line treatment of hormone-positive, HER2-negative advanced breast cancer. And we know that palbociclib got accelerated approval on the basis of improving PFS from the PALOMA-1 trial, and PALOMA-2 was a confirmatory trial to convert that accelerated approval into regular approval. And as we have discussed sometimes about how confirmatory trials sometimes use the same surrogate endpoint as they have used in accelerated approval, that's exactly what happened here. PALOMA-2 PFS was improved, and therefore palbociclib's accelerated approval was converted to regular approval. However, the ultimate marker of clinical benefit is overall survival, and that's a problem because we approved this drug as regular approval without waiting for overall survival or based on progression-free survival alone. Anyways, the results of the PALOMA-2 overall survival were presented at ASCO, and it shows that the addition of palbociclib to first-line endocrine therapy did not improve overall survival. So the overall survival was not improved. There was no benefit in overall survival. Now, there are a number of reasons why that may have happened, and there are a number of things to consider in the interpretation of these results. But one is about the approval systems that I already talked. I don't think it's appropriate to use the exact same surrogate endpoint for regular approval that we have used for accelerated approval, but also about the presentation of data. If we looked at how overall survival results from PALOMA-2 were presented, as I said, it was not significantly improved, but you will see languages that might mislead, such as there is a numerical difference, although it was not statistically significant, and continuing to say that there might be some subgroup of patients who will have overall survival benefit. For example, they were claiming that for patients with a disease-free interval of more than 12 months will have an overall survival benefit. But these are all random post-hoc analysis. And in fact, these are quite arbitrary. These are all a way to spin the results, because why not disease-free interval of 18 months? Why not disease-free interval of 6 months? You might very well say, if we do an analysis among the survivors only, then there is a survival benefit. These are all random post-hoc maneuvers to show a statistically significant result. In fact, they even tried removing all the patients who were lost to follow-up. Like, usually we include all these patients and censor them, but instead of censoring them, they also tried to exclude them and do the analysis, and even then it was not statistically significant. This is not a right statistical practice, but even then it was not statistically significant. They also tried to combine the results of PALOMA-2 with PALOMA-1, again a post-hoc approach. This was not a pre-planned thing, and tried to look at the overall survival, but the bottom line is it did not improve. So the other thing to consider here is, what does it mean that the addition of CDK4/6 inhibitor palbociclib to frontline endocrine therapy did not improve overall survival? The argument here is probably that the control arm did far better than what we expected. The overall survival was 51 months, in the range of 51 to 54 months in the control arm and the palbociclib arm. So yes, that's a long overall survival, longer than what they might have expected in the control arm. But having said that, it probably means that with all the improvement in treatments and diagnosis and everything, the natural history of the disease has improved. And most importantly, I think it also means that getting palbociclib in later lines of treatment will probably lead to same overall survival advantage as giving it first line, because there is no doubt that CDK4/6 inhibitors are an important class of drugs for patients with hormone receptor positive breast cancer. But if we are failing to improve overall survival in frontline, in first line setting, what that probably means is you can reserve this drug for second line or later lines of treatment and still achieve the same survival benefit. That way we would be treating fewer number of patients. for a smaller duration to achieve the same benefit. So the take-home message for me is that you could probably reserve palbociclib for later lines of treatment. You probably do not need to give it upfront, and that also means that there are probably a substantial percentage of women with advanced breast cancer who will do well with endocrine therapy alone for the first line, and we can use palbociclib when they progress on first-line endocrine therapy, which may be after several months. Having said that, one more thing that came to my mind when I saw those results were, ribociclib has positive OS data. And if you look at early breast cancer, abemaciclib so far has positive DFS. It may change, it may become negative with more mature follow-up, but palbociclib trials were clearly negative in early breast cancer. So palbociclib failed in early breast cancer. Even in advanced breast cancer, palbociclib could not improve OS when the other drug did. So does that mean palbociclib is the weakest of all CDK4/6 inhibitors that are available? That might be a question to ponder. Until now, we have been treating all CDK4/6 inhibitors as if they are similar, but is there a possibility that they are different? That might also be a question to think about. So just sharing some of my thoughts about the PALOMA-2 trial and CDK4/6 inhibitors in advanced breast cancer. Thank you.